Hi, everybody. Today we are going to go over labor and birth. So I'm going to share my screen and we are going to get started. So for labor and birth, we're going to have a baby today. And so we're going to consider how we're taking care of our patient through all of this. And the first thing you guys should do is look in your book at your key terms, and they're on page 121. Okay. The other things that we want to think about when we're taking care of our patients is our cultural considerations. And so some things that we think about has to do with the way that the role that the father plays. It affects how she views a lot of different things, whether it has to do with breastfeeding, pain. Some women are very stoic, what they can eat, what they can't eat, whether or not there's a multitude of things. So some of the things that we're thinking about for this, we need to be very flexible. We need to be very accommodating, and we need to be culturally competent. So we are acknowledging what's important to them. We are acknowledging what their needs are. And the terms on here, that's the cultural competence. Ethnocentrism has to do with the belief that your culture is correct. It's the rightness of your own beliefs and not being accepting of other thought process. So it's kind of the opposite of cultural competence. And that can apply to your patient. But we don't do it that way at home. Okay. And this is the way we do it. This is the right way to do it. It can also be you as a nurse. I've been doing this for a long time. I know how to get your baby out. You should listen to me. So there's a lot of things that go with ethnocentrism and the belief that your way is the right way. And the other thing to keep in mind is cultural relativism and how we relate the care items that need to happen into what's important to them for their culture. So asking open-ended questions and seeing, well, what does your culture do in relation to breastfeeding? And then you can take the things that need to happen for breastfeeding and apply that to what's important to them. Okay. And so then we are looking at the different places that people can deliver. Where can they give birth? You can give birth in a hospital, and that's the traditional way, right? You get in the car and you pack your bags and you go to the hospital. This is going to be, for some, considered the safest way to do it. And the reason why is because the things can happen in labor that can be truly tragic. And if these things happen at home, it is a lot more difficult to get emergency care in the time frame you need in order to resolve your problem, preserve the baby's life, whatever. There's a lot of thought, though, that in the hospital, even though we try hard to wash our hands and to be very clean and things like that, that you have a higher chance of contracting an infection in the hospital that you wouldn't have at home because you're around kind of your own environment. Also cost. Delivering in a hospital is a lot more expensive than delivering at home. Who can be with you in your labor? You know, if you want to have a water birth and you want your husband and your kids in the tub with you, and you want, grandma and whatever, that might not work in a hospital setting, but you might be able to make those kind of arrangements if you delivered at home. Birth center is a nice middle ground. A birth center is a nice place that has kind of a home-like feeling. This is going to be your low-risk pregnancy. They have a little bit of a safety net this way so that if something does go wrong, they can much more quickly have access to emergency care. But the birth center is going to still give you a little more autonomy, I think, is the thought with this. Hospitals are really moving towards improving this. They're really moving towards family-centered care. At the hospital I work at, we have a lot of things on our birthing unit where we are being very accommodating to position changes, water therapy, lots of different tools to use, peanut balls, cub seats, And then we can do, and we'll look at fetal monitoring in a minute, but we can monitor intermittently so they don't have, monitors on them all the time, but there's still a safety component to that. So you still have to find that middle ground. Okay. So there's a lot of considerations for this when we're thinking about what the mom's needs are, what she wants. And truly also, what if she wanted to have a home birth? She wanted to deliver in a birth center, and now she has a high risk pregnancy, and that's not a safe option for her. How do we support that? And how do we give her a similar experience in a setting where we can keep her and her baby safe? So labor and birth, factors that affect labor. So I'll call it the P's, okay? And we have our passenger. And our passenger is actually passengers because our main passenger is our baby. Okay. And what we're looking at for our baby is what position is the baby in? What is the presenting part? Okay. Is it coming out breech? Is it butt first? Is it head, which is the ideal way to come out? Is it transverse sideways and it's like the shoulders coming through? So then that tells us if we're looking at position, we're looking at presentation. And I'm going to show you guys attitude in a minute on the next slide. We have to have a baby head down to deliver vaginally. If our baby is transverse or if our baby's breech, then she's going to need a C-section. Okay. Years ago, they did deliver breech babies vaginally. There's a lot of risk that goes with that. After the body comes out, sometimes the cervix will start to close down on the baby's head and you get head entrapment, which is a horrible emergency. So babies need to be head down to deliver vaginally. Okay. The other passenger here that we're considering is the placenta. And so later when we are having a baby, then that delivery of the placenta is one of our stages, and it's stage 3. And so we have some considerations that go with that as well. And we have considerations in labor too. Where is the placenta? Does it affect our fetal monitoring? Things like that. Okay, because if it's anterior, it's harder to find our monitor externally. Passageway is our passageway. It's the pelvis, it's the vagina, it's the cervix, it is the birth canal. Okay, and then power. What brings the power? Contractions bring the power, and so does mom's pushing effort when she's delivering. And then the last P is psyche. How is she coping? How is she responding to her labor? Is she calm? Is she controlled? Is she anxious? Is she having a hard time with coping? Because this affects a lot of factors with how her labor progresses. So, and also true too, depending on how she is psychologically handling her labor is going to affect the way that we're able to help her. Okay. So here's what we're talking about with our passenger. All right, we have a few considerations for this. So what we're thinking about, let's talk first about presentation. I'm actually going to stop this way so I can zoom in on these pictures because I want to look at them closer with you guys. So let's zoom in on let's do presentation first. And so this picture has to do with abnormal presentations when we look down at the pictures here. Okay, but so the presentation is what's coming through the pelvis. What is the presenting part? Okay, and so we already said if it's breech, then whether it's the baby's bottom or its feet, that's going to be a C-section delivery. If it's a shoulder, this baby is transverse, and this has to do with the lie, longitudinal lie. If the baby's shoulder is coming through the pelvis, that is also a C-section. These are other abnormal presentations, and these relate to the next thing I want to show you. And this has to do with the attitude. And with attitude, what we're thinking about is the definition says it's the relation of the one part to another part, and that doesn't make a lot of sense to me. So we're thinking about where the head is in relation to the body, and we're thinking about flexion versus extension or deflection. Okay, and I don't know why this is highlighting practice question. There we go. So this baby in number A, you can see how he has his chin kind of tucked down like this. That is the best way. That is a flexed attitude. Okay. And that is the best way for the baby to come through the pelvis, because when the baby's chin is flexed down, the baby comes through the pelvis with the narrow part of the head. In our baby B, this baby is deflexed. And so he's not flexed. He's not extended, but he's not flexed. He's just hanging out. And he's going to come through the pelvis with the wider part of his head this way. So that makes labor more difficult. Okay, these other two here are going to be different types of extension. So if you look at C and D, now we go back down here to presentation, you see here's our brow presentation is like C, and our face presentation is like D in our attitude. And these, the brow presentation might make it out vaginally, the face presentation probably won't. Okay, there's one way with a face presentation we might get a vaginal birth, but usually not. Okay, so the way we want the baby to be is we want this part of their head coming through the pelvis, and we call this vertex, which is right here. All right, vertex. And that's the ideal. And so if I have a baby that has a flexed attitude, he's vertex. And truly a deflexed attitude is also vertex. But if we have extension, then we have a brow or we have face. Okay. Now, when I'm thinking now about coming through the pelvis this way, like A, the best way to do that is going to be based on the baby, where the baby's facing in relation to mom's pelvis. So what we think about for this, and there's a lot more information about this stuff in your book, guys, but what we're looking at is the pelvis itself. And so if this is the pelvis, this is mom's back, it's posterior. This is mom's front, anterior. And when we think about the baby's position in relation to mom's pelvis, just to keep it complicated, we're not going to talk about which way the baby's facing. We're going to talk about where the occiput is, which is the back of the head. And so wherever the occiput is in relation to mom's pelvis is going to be our position. And so if the occiput is towards mom's back, then think about the fact that if the occiput's towards mom's back, the baby's face is facing mom's front. And we call this occiput posterior. The occiput is towards mom's back. And this one in the picture, the baby's a little more right or a little more left. So we're saying right occiput posterior and left occiput posterior. If we are occiput posterior, these babies are most often our babies that are deflexed and come through the pelvis wide. And that's what this other picture is an example of here. So you can see this baby, you can tell where the back is. Occiput is to her posterior, and the chin is deflexed. The baby is not tucked down. And so instead of coming through the pelvis with this narrow part of the head, the baby's coming through wide. And that makes labor more difficult. And truly, it often is the culprit for back labor. For anybody who's had horrible back labor where that back pain was so bad, this is often the culprit of that. Okay. The most ideal way for the baby to come through the pelvis is occiput anterior. So the occiput is towards mom's anterior, which means the face is facing towards mom's back. And when the baby is occiput anterior, now we get a nice flexed baby. And so this is the most ideal way for the baby to deliver vaginally. Babies that are occiput posterior can deliver vaginally, which is harder usually. 3 of my 5 delivered that way. Okay. So these are our positions, our presentation, our lie, all of this with our passenger. The other thing I want to look at here is our station. And our station has to do with where the baby is in relation to the pelvis. So when the baby drops, into the pelvis. So towards the end of pregnancy, moms will all of a sudden go, oh, I can breathe so much better, but now I have to pee so much more, and the baby has dropped down. And we actually call that lightning. And when the baby drops down, we can start to feel the presenting part if we did a vaginal exam. And if we can reach the presenting part, then it's usually somewhere in this section here. If it's higher than -3, I can't really feel it. All right. So the actual measurement of station has to do with the ischial spines of the pelvis, and you could feel them. If you were to digitally check for cervical, for the station and for the cervical dilation, fingers in the vagina, and you rocked your fingers to either side. If your patient wasn't obese and things like that, you could probably feel where those ischial spines are. And that is our landmark. When you've been doing this for a long time, you kind of just get a feel for where that is, and you don't try to feel it every time. So ischial spines is 0 station. Anything higher than that are minuses, -1, -2, -3. And when we're getting down towards the opening of the vagina, towards birth, we're in the pluses, +1, +2, +3. Okay, so when I'm measuring a cervix and I'm measuring a station and then doing all these measurements, if you go clinical, you hear she's 380 -2, she's 3 centimeters dilated, she's 80% effaced, which is how thin the cervix has become. And then the -2 is where this baby is in the pelvis, -2 station. Okay. All right. So that's our passenger. So if we do a practice question, after doing Leopold's maneuvers, the nurse determines the fetus is in the ROP position. To best auscultate the fetal heart tones, the Doppler is placed where? So let's think about ROP. Right occiput posterior. If the occiput is on mom's right, so is the baby's back. Okay, and then if the occiput is posterior, the baby's facing out more towards the front. And so the head is down. We have the baby's back is on the right. So we're going to be looking for heart tones below the belly button and on the right side, because we look for heart tones along where baby's back is. And so right occiput posterior would be over here. Okay, mom's right side. You're looking at that, and that's your left. It's mom's right side. The occiput's on mom's right, so is the fetal back. Okay. Signs of preceding labor, signs that labor might be starting. So the baby drops, which we just talked about in relation to station. Lightning is what that's called. Okay, Braxton Hicks contractions. Braxton Hicks contractions, guys, I'm going to show you a little kind of fun video that gives you an example of this. But Braxton Hicks contractions are irregular contractions, and they don't really change the cervix. It's kind of practice contractions. The uterus is getting ready for labor. Increased vaginal mucus. This is going to, in the end of pregnancy, there's a lot more discharge. There's more mucus, there's more discharge. In general, women are like, sometimes, my underwear is wet, I need to wear a liner. Is this my water? All right, and it's usually more mucusy because it's related to that. And then oftentimes then the mucus plug comes out as well. And the mucus plug is going to be, if you guys remember from, I think, week 2, that build up, it might have been week 1, that buildup that sits inside the cervix. All right, when we're getting close to labor, that comes out, and the mucus plug has a lot of blood content to it. So it looks like, we call it bloody show. Okay, it's not the same as a period like bleeding. It's not the same as hemorrhaging bleeding. It's just mucusy and bloody. And it's kind of, well, it's a plug. It's a clump. Okay. So the cervix might start softening. So the cervix in a non-laboring woman usually is firm, it's thick, and it's closed. It's holding that baby. Okay. And when labor is getting close to starting, or later when we talk about inducing labor, if I want to make her go into labor, I need this to soften up. Okay. If you think about like trying to push on a closed door, it's not budging. And if I give her contractions, if I give her Pitocin and I make her uterus contract, and this cervix is firm and solid and thick and closed, I'm not getting anywhere. So the body starts releasing its own prostaglandins that soften this up and make it nice and squishy. And then if she gets contractions, whether she goes into labor on her own or later we're giving her contractions, if this is soft, now it's like pushing on a door that's cracked open a little bit, and now it's going to be more likely to open and thin out. So the cervix starts to soften. Maybe the water breaks. Okay, sometimes it breaks before labor starts. And so that it can be a consideration as well. We tell women to go to the hospital if their contractions are increasing in frequency and intensity. So there's a lot of, I don't want to say anxiety, but kind of anxiety that goes around that. I'm having contractions. When should I go to the hospital? I don't know. And I don't want to have my baby at the house and whatever. If their contractions are increasing in frequency and intensity, then they should go to the hospital. So if they're increasing, like I used to have 1 contraction a day and now I have 3, but if we're having regular contractions, like 5 minutes apart, they're lasting for a minute or they're getting stronger. They're not, and in a minute, we're going to look at true versus false labor. They're not going away if I walk around. They're not getting better. Should go get checked out. If the water breaks, you should go. Bleeding, more than bloody show or a little bit of spotting. So as this cervix starts to soften, little capillaries in here start to break. And so you can have, not only can you see the mucus plug with your bloody show, but you can also have a little bit of spotting. That's normal. More bleeding than that should go to the hospital. Okay. And then if the baby's not moving. Okay, we should always want to get checked out if they're not noticing fetal movement. So we had talked about kick counts before and making sure the baby's moving daily. And so if they notice that they're not getting as many kicks or they're not feeling kicks at all, that's the other time they should go in. So here is kind of an example of our Braxton Hicks contractions versus regular contractions, effacement and dilation.
Hey, Charlotte. So I'm going to show you how we do the ping pong ball and balloon exercise. This was something that I got from a fantastic workshop called Stomp Out Boring Childbirth Classes. If you ever have a chance to attend that workshop, it's fantastic. So first part is we need to get the ping pong ball in the balloon. And if you just put it in, if you just try and open it a little bit and put the ball in, it's going to get stuck. And as I always said in class, stuck is a word we don't like to have associated with childbirth. So what you have to do is get your fingers all the way to the very bottom of the balloon and crank it way open and then poke the ball in. And then you have that. And I would usually have the class do that, stuff their own balloon. It was always fun and would have a good joke about it. And so then we've got that ping pong ball in there and we're going to inflate it about halfway. About like that. And then you can let that ping pong ball settle into the neck of the balloon. Sometimes giving the neck a little tug really helps. And then you can let go of it and it'll stay inflated. And I show people how if you just squeeze the side of the balloon like this, not much is happening to the neck of the balloon here, and it's not opening very much. These are the Braxton Hicks contractions that are just practice contractions that are more and more common towards the end of pregnancy, but they don't do all that much to what's happening to the cervix. So real contractions happen at the top of the uterus. That's where the power of contractions happens. It's the muscle fibers at the top here getting shorter and thicker, which squeeze the top and then pull up on the side of the uterus here. And just like with real contractions, I have everybody just squeeze and then let go. and then just squeeze and let go. You just have to do a little bit at a time. And you can see how we're getting that effacement or thinning of the cervix down here, and not much dilation is happening while we're still working on shortening the cervix here. And this is a lot of the work that's going on in early labor. It's mostly about that shortening and less about the dilation. So once we get to much more effaced, much more thin, then we're going to start dilating the cervix there. And a lot of people get kind of nervous at this point. It's like, oh no, it's, you know, I don't want to push. So we always have a bit of a joke. It's just like actual labor, where you'd be like, it's okay, just breathe, do it gently. You're stretching beautifully, and then just give it one more push, and the baby will be here. There you go. And it's always just an absolute rioting class.
Okay. So you can kind of see how those Braxton Hicks irregular contractions don't make a lot of difference to the cervix. And that when we start getting into real true labor contractions, that's where we're going to get effacement dilation. And so I have this little example too, that because I'm kind of a visual person. And so for your cervix, not only are we looking at how much it's opening this way, but we're looking at that effacement or that thinning. And so this is my example of this. So both of these are, I'm going to say about 1 centimeter based on, for as long as I've been measuring things with my fingers, I know that my finger is about 1 centimeter. And if I put my finger through here, you can see how thick this is. And so if this was a cervix that I was checking and I put my finger in there and I felt this thickness, I might say that it's not effaced, 0%. All right. Now, if I put, this is also this approximately the same width. Okay. It's actually a tiny bit smaller, but for our purpose, it's the same. All right. So now if I put my finger through this one and I say this is 1 centimeter, you can look at these next to each other and see that this one is more than halfway less or thinner, and that, and but not quite a fourth here. So if I was checking this cervix and I felt this thickness, I might say that it's about 70% effaced. Keeping in mind that this is 0%, I might call this 70%. So that's one of our numbers. If I say she's 0% effaced, -3, that's our station in the pelvis, or she's 70% effaced, and then whatever station she's in her pelvis. So that's effacement, the thinning. Okay. So going back to our video, well, the video's over, but going back to our PowerPoint, I'm gonna make it play again and blow it up bigger. Okay. So the amniotic fluid. So the amniotic fluid, if you guys remember what the amniotic fluid, where it is, what it does, right? It's around the baby. And if the membranes that surround that break, the fluid comes out. And this usually happens at some point during labor. So it might happen as a preceding sign of labor, the water might break. It might not happen till active labor when she's laboring. It might not even happen until the very end when she's ready to push. And when the water breaks, I want to know what color it is. And so if we were all sitting in a classroom, I would ask you what you would expect to see. What color should it be? And what I'm thinking about for amniotic fluid, guys, is I want it to be clear. Okay. It might have some white little flecks in it. And so the white little flecks are caused by vernix from the baby. Vernix is something that is on the baby's skin that helps protect the baby's skin. And if you see vernix on a baby, it looks kind of white and cheesy. So if it is in the amniotic fluid, that's normal. Little white flecks are normal, but otherwise I expect it to be pretty clear. Okay. If it is cloudy, if it is yellow, if it is green, That's signs that something's wrong. And it also shouldn't really have a smell to it. Okay. So if it has an odor to it, something's wrong. So usually green, guys, is an indication that the baby passed their first bowel movement, which is called meconium, while still inside. And we're going to learn more about that in a different week. But this is something that if the baby passes meconium in the amniotic fluid, remember that amniotic fluid can go into the baby's lungs. And meconium is sticky. And so we can have some problems with that. It can cause a pneumonia for babies. Okay. But if it's yellowish, if it's cloudy, if it's stinky and odorous, I'm thinking infection. All right. And so the things that we want to consider for this is if her water breaks, I want to know what time. I want to know how much. And we can quantify this as like scant, moderate, or large. If she's got little trickle, it's scant. If she had a little bit of a gush, it's moderate. And if she had a big gush, I had a patient one time, her water broke. Water ran off the bed and over to the door. That would be large. Okay. So I want to know the color. I want to know the time. And I want to monitor the baby after the water breaks. Because then when the water breaks, now we have less of a cushion on that umbilical cord. And truly too, a very emergent situation that can happen when the water breaks is if the water rushing out brings the umbilical cord down and in front of the baby's head. And we learn about this in high risk complications in labor and birth, but this is dangerous. And so these are things I can see by monitoring the baby. So I want to monitor the fetal heart tones for a minute after the water breaks to just make sure that my baby looks okay. And then I want to know the time and the color and if there's odor and those things. Okay. 7 cardinal movements of labor. I'm going to give you guys an example of this, but these are the steps. These are the 7 cardinal movements. These things happen. They're cardinal movements. So engagement is the baby engaging the pelvis. It descends down into birth canal. We get flexion. Okay. Some more than others, like we were talking about with attitude. And then the baby rotates internally. As the baby's head comes out of the birth canal, they extend, then they rotate externally, and then they deliver. So I'm going to show you that. But first, let's just touch on what's going on with baby in labor. Okay. With baby, we expect the heart rate to be between 110 and 160. That's our range. All right. But we need to be mindful that there's certain things that affect the way that babies get oxygenated in labor. And we've talked about this in relation to supine hypotension, vena cava syndrome. Okay. If mom's blood pressure is low, she's not perfusing her placenta well. So that's going to affect fetal circulation. Maternal position, supine hypotension, can affect fetal circulation. But also true, guys, the contractions can also affect this because that the placenta is attached to the uterus and all of the vessels come through the uterus to the placenta. So when the uterus squeezes and contracts, it's squeezing those vessels that feed the placenta. All right. So if we have contractions, we're going to look at what we want for contractions timing wise. If we have contractions that are lasting too long, they're lasting longer than 90 seconds. That's kind of like asking the baby to hold his breath, right? Because that's where the oxygenation comes from. And so for however long that we are squeezing and tamponing those vessels, we have less perfusion to the placenta and we have less oxygenation to our baby. So that affects our fetal circulation. And then the other thing is how is things flowing through the umbilical cord? If I have great perfusion to the placenta, but I have a cord that is getting compressed, I still have less blood flow to my baby. Okay. And so these are all considerations in labor. The other thing we're thinking about with our baby, remember the amniotic fluid has been in those alveoli. And as soon as this baby comes out and takes a nice big breath, I want gas exchange to happen. And if the alveoli are full of fluid, it's not going to work, right? So the baby's body, before it's born, starts kicking that fluid out of the lungs. Okay. And then on top of that, as the baby's coming through the birth canal, we get a nice squeeze on the chest. And this also helps to clear that out. And then when that squeeze releases as the baby's body comes out, it causes that breath. Okay. So these are all things that we're thinking about with baby in labor. So let's look at our cardinal movements this way. So here's our cervix dilating and effacing, and our baby coming down. There's our descent. Okay. And so as our baby's coming down and descending, now we have that internal rotation. And then we have extension here where the head extends to come out of the birth canal. Then we have external rotation and then expulsion. So we'll watch it through one more time. And here, let's pause this. Oh, I can't pause it. Right then, where we have this external rotation, this baby's shoulder was nice and under the bone here. Sometimes that's not what happens. And if this shoulder gets hung up on the bone, we have another emergency. And that's called a shoulder dystocia. So what am I assessing? What do I want to know when my patient comes in? All those things that we talked about in relation to when she first started her prenatal care, those are all things that are important to know. I want to know what her history is, if she's using drugs, if she's using alcohol. I want to know what her health history is. I want to know what her obstetric history is. Is this her first baby? Is it her fifth baby? Okay. I want to know gestational age. How I take care of her if she's 28 weeks is different than how I take care of her if she's 30 weeks gestation, right? I want to know if she's contracting. I want to know how her baby's doing. Really, the first thing we do is we walk in the room and we start asking our questions while we put monitors on her belly. And we're looking at the non-stress test. We're looking at the baby's tracing. And I'm going to show you guys what I'm looking for on that. Okay. I want to know the membrane status. Is the water broken? If it's broken, what color was it? What time did it break? Okay. Fetal position and presentation. So I can do Leopold's maneuvers, which we learned about in week 2, where we put our hands on the belly and we can feel the top, and then we feel down the sides, and then we feel at the bottom to determine where's the baby's back and is the baby head down. Okay, so I can determine my position and presentation by doing Leopold maneuvers. Physical examination, vital signs, lab work. If she's going to stay and have a baby, we're going to check her blood type, right? And the RH. I want to know what her CBC looks like, things like that. Things to tell the doctor about. Vaginal bleeding. Okay, especially remember we talked about placenta previa. One of the first things you want to do is tell the doctor if your patient's bleeding. Okay, but if I have more than a little bit of bloody show, I want the doctor to know, or whoever the primary care provider is. Acute abdominal pain, because we talked about, as an example, we had talked about the placental abruption. And how that causes the rigid abdomen and the abdominal pain, the pain in the belly. Temperature greater than 100. Preterm labor. So remember, preterm is before 37 weeks. Premature SROM. What is SROM? This is spontaneous rupture of membranes. If the water breaks and she's preterm, I need to tell the provider right away. Hypertension. Okay, greater than 140/90. non-reassuring fetal heart rate tracing, which we're going to look at in more detail in a minute, and other alterations in the patient's condition. If you're worried, you should talk to the doctor or the primary care provider. So keep it in mind, and this relates to what we were also saying about how the blood flows to the baby. Okay, keeping those things in mind. What affects our oxygenation? Okay, we need to remember that the whole point of all of the monitoring we do on babies in labor is to make sure that that baby stays oxygenated, to make sure that we are not developing an acidosis, because if the baby becomes hypoxic, they become acidotic, and that is what causes things like cerebral palsy. So fetal oxygenation can be decreased by all of these things: reduced blood flow due to hypertension, hypotension, and hypovolemia. So that goes back to what we said, that the placenta depends on maternal blood pressure for perfusion, okay? Alterations in fetal circulation because of pressure on the cord. So we talked about that on the previous slide. There's pressure on the cord, that's going to affect our blood flow to the baby. And then reduction in blood flow to the placenta because of the contractions. So we call it hypertonus or tachysystole. Hypertonus is hyper or a lot of tone. Tachysystole, tachy is fast and systole is contraction. Okay. So ways that we can monitor our baby. We can do intermittent auscultation, and this is great for your low risk moms. So when we were talking about home birth and we were talking about birth centers, these are places where they have less interventions and less monitoring. So intermittent auscultation is probably something that is happening very frequently. And also true in the hospital setting. If the patient's low risk, and there is, if we check our policies and procedures, there's an outline of what can and can't have intermittent auscultation. If we have low risk, we can have intermittent auscultation where we just listen to the baby on a schedule. So my patient last night came in 7 centimeters dilated. She had a reactive tracing. Her baby looked great. Her labor was progressing normally. She was low risk. So I took all those monitors off, and every half an hour I set it on and I listened for 1 full minute. Okay. And that gave her the freedom to move around and do the things she needed to do for coping with her labor. So fetal monitoring, the idea behind fetal monitoring is to assess the oxygenation during labor. And like I had just said, if we have abnormal patterns, that is giving us an indication that we could have hypoxia. And if the baby is hypoxic, they can develop the acidosis. So different ways we can monitor our baby. We can do an external monitor, and our external monitors is most often what we do. Okay, we don't routinely put internal monitors in unless there's a reason. And so our external monitor is little round circle, and we put the one that we want to listen to baby with. So on that practice question of where would we put our monitor, we want to put it where the baby's back is and close to where the baby's head is, because we're trying to put it close to the fetal heart. And so that little circle goes on the belly, and we strap it on with just an elastic strap. And then the other thing is a TOCO transducer, and the TOCO transducer has a little button that notices pressure. And it's not measuring strength, it's just noticing pressure. And we put it towards the top on the fundus, and we put a strap on that too. And then we trace it. And we can see when the contractions happen, and we can see how the baby's responding. Okay. Now, if I'm having a hard time tracing my baby, or I need to quantify my power, remember our P's, I might use internal monitors. And so my internal monitors, the fetal scalp electrode is a fetal scalp electrode. It goes on the fetal scalp. And so it goes in through the vagina, through the cervix to the baby's head. And it's got kind of a tiny little, it looks kind of like the end of a spring. and it goes right under a couple layers of skin on the baby's head. And this will trace our baby very accurately. And then the intrauterine pressure catheter, or IUPC, is intrauterine. It's going to go into the uterus. So through the vagina, through the cervix, into the uterus. And it's a pressure catheter. So it notices and measures the pressure of those contractions in millimeters of mercury. So this is how I can quantify my power. Okay. So I need a cervix to be dilated. I can't put monitors in there if the cervix is closed. If we have a cervix like this, my monitor's not going in there. All right. So this brings us to fetal heart rate tracings. Okay, so this is what I'm looking at. Am I oxygenating? Is my baby oxygenated? So we're looking for that normal baseline, 110 to 160. Okay, we're looking at variability. And variability, I'm going to take us back out of slideshow mode because I'm going to jump around for this. So variability is the give and take. Let me do this other slide for variability first. This is our squiggly line. This is the give and take of sympathetic and parasympathetic. That it speeds it up, slows it down, speeds it up, slows it down, and it makes a squiggle like this. Okay. And if I have good variations here, if I have good variability, this is a really good sign that my baby is well oxygenated. Okay, so this part is a thing that can give us an indication that the baby's doing well and is reassuring. And so there's different types of variability you're going to see, and depending on what's going on with your baby. The one that I want, the one that's best, is moderate. And if we look closer at moderate variability, we want to look at, you see that it says it's 6 to 25 beats variation around the baseline. So how do I know what the baseline is? And so the baseline is where my heart rate hangs out the most, right through here. Okay, and I can look at this and say, this is the baseline, and I can look at these variations around that, and I can see that I have fluctuations that are greater than 6 to 25 beats. And I know this because each line here counts as 10 beats. All right, so if I have variations that are going up and down from one line to the next line, that's 10 beats. Okay, that doesn't even include these big hills over here. And this is actually, this part isn't actually variability. This part, this big hill, is an acceleration from the baseline. So our variability is this squiggly line in here. Okay, now if I have less, the other one that you would most commonly see is this one, minimal variability. And you can see now that our squiggle around this baseline is less, and it's less than 5 beats of a variation. Okay, minimal variability. So here's what's happening with minimal variability. Maybe my baby's developing an acidosis. Maybe my baby's taking a nap. Okay, we don't know. So this is something that requires us to monitor and potentially do something about. If it's minimal for half an hour, I'm not worried because my baby might be sleeping. But a newborn or a fetal nap doesn't take more than probably 40 or 45 minutes. So if it's been minimal for an hour, something's up. Okay. Now the other ones are absent, which is really nothing. No detectable variations around the baseline. And the other one is marked, and marked is very chaotic. It's greater than 25 beats of a variation. Okay, so keeping in mind that each one of these lines is 10 beats. So most often though, you're seeing moderate or minimal. Okay, moderate is the best. We like it. So the other slide that had the variability just puts them like this where you can see them a little better. And minimal We got to kind of get up close to see we have variations there, but we do. But you can see with moderate, and it doesn't follow a pattern. It's just kind of does its thing. That's why it's variations anywhere between 6 and 25 beats. So that's variability. Okay. Now let's look at accelerations. Accelerations are going to be an increase from our baseline. And it's going, in order to count as an acceleration, it needs to be at least 15 beats from the baseline upward and last at least 15 seconds across. And that's going to be true as long as your baby's gestational age is over 32 weeks. If your gestational age is before 32 weeks, then we say 10 by 10 instead of 15 by 15 because their neurologic system isn't as developed yet. Okay, this is very reassuring. If I have a baby that has moderate variability, if you look along the baseline here, we have that good squiggly line that has variations that are more than 5 beats. So this is moderate variability. If I have moderate variability and I have accelerations, this baby is well oxygenated. This baby is neurologically intact. This baby is doing everything I need to see to be reassured. So is the tracing reassuring? Yes, I'm reassured. Is it reactive? So we do reactive and non-reactive for a non-stress test. A non-stress test is going to be the same idea as this continuous monitoring, except I'm only looking at a picture in time. I'm looking at 20 minutes. And in those, so that's going to be like your patient that goes into the clinic. Maybe she's diabetic and we are monitoring her baby every week, just checking on fetal well-being. Then we do a non-stress test where we put her on the monitor for 20 minutes. We are not giving her contractions. We're not causing stress. And we're just seeing how the baby's heart rate looks. And we're looking for moderate variability. And in a non-stress test, I want to see 2 accelerations in 20 minutes. Okay. So it's very reassuring. If I have 2 in 20 minutes, it's reactive. Okay. So that's what we're thinking about with fetal monitoring as far as things that are good. Moderate variability, accelerations. So now let's look at what things we worry about. All right. And if we go, we'll do it on this slide. Let's do that one last. Let's look at times when the heart rate slows down. Okay, so an early deceleration, we're going to talk about this first. And this one actually isn't one that I worry about, but it is a slowing of the heart rate. And so let's look at it. And what's happening with an early deceleration is an early is kind of on time. So the contraction happens and the deceleration times it with the contraction. And so the baseline is here, and as the contraction starts, the heart rate decreases, and as the contraction resolves, the heart rate returns back to the baseline. And this would look better if I was an artist, but we want the peak of the contraction and the nadir, or the bottom of the deceleration, they should be pretty even with each other. And the beginning of the contraction and the beginning of the deceleration should be even. And the beginning or the ending of each should be even. Because with this, they mirror each other. The deceleration and the contraction are mirror images of each other. Okay. And with this, what's causing this is head compression. It's pressure on the head as the baby's coming down through the birth canal. And so this is a normal physiologic response to the process of labor, and it's not actually concerning. But we still need to observe for it, and we still need to document. Now, if I look at the other part of this tracing at the baseline here, I have minimal variability, right? But right now we're just looking at the decelerations. Let's do the late deceleration next. This one is the one that I worry the most about. Okay, and here's what's happening with the late deceleration. With the late deceleration, the contraction's happening. Okay, and the baby's heart rate is at its baseline and the contraction starts, and not until probably the peak of the contraction does the heart rate start to go down. And then well after the contraction's over, the heart rate comes back up to its baseline. So you can see that the contraction began here, ended here, and my deceleration had not yet resolved. Okay, these are called late decelerations. And the thing that causes a late deceleration is caused by placental insufficiency. So all of those things we were just talking about that affect the way that we perfuse the placenta, the way that we oxygenate the baby through the placenta, blood pressure, hypovolemia, if we have contractions that are lasting too strong or too long, these are things that are going to cause our late decelerations. And late decelerations are the biggest indicator of hypoxemia. These are our babies that are not getting oxygenated. Okay, these are the ones I'm the most worried about. Now, the other one is our variable deceleration, and these ones look worse. Okay, but let me tell you what's happening with this. So with these with these decelerations, these are called variables. Not to be confused with variability. Variable. And the reason it's called a variable is because the relationship to the contraction is variable. It's not related to a contraction necessarily. And the reason why is because the cause of it is not caused by the pressure of the contraction. It's caused by pressure on the umbilical cord. So if you guys remember, we have 2 arteries and 1 vein. And the vein has the oxygenated blood that's going to baby. The arteries have the wastes and whatnot that's coming out. When pressure happens on the umbilical cord, I have less blood flow going in. I have less blood flow going out. And the baby's heart rate adjusts for this because it changes the blood pressure inside the baby. Because we have less going in, less going out, the blood pressure changes in the baby. And because of a whole physiologic process you don't need to know, with baroreceptors and stuff like that, the baby's heart abruptly drops. Okay. Now, as soon as this pressure releases, and so this might not be pressure from a contraction, guys. Maybe the baby is laying on its cord. I had one baby we ended up doing a C-section for because we couldn't figure out why we were having these big variables. The baby was holding the cord in his hand and squeezing it. Maternal position can affect the pressure on the cord. There's a lot of different things, okay? So once that pressure resolves, the baby's heart rate comes right back up to its baseline. And then it goes back onto its baseline and along its merry way. Okay. Now, can this cause hypoxia? It still can. All right, depending on like this in the picture, these are really deep variables. And so the nadir or the bottom of these is going really low. And so we have a lot, we are getting less, we have more pressure on the cord, less blood flow through the cord, and so less oxygenation over time. But in between, the pressure on the cord releases, and now we have oxygenation and the baby is regaining the reserves. So this one is not as worrisome as this one, the late. And the variables, and it follows the same rule as accelerations. So you remember that accelerations needed to be 15 beats times 15 seconds. And this is going to be true with our variables as well. That it's going to go down by at least 15 beats from the baseline and last for at least 15 seconds to be considered a variable deceleration. But the key for this is that abrupt drop. Okay. And so this is caused by core compression. So how do I remember what causes each of these things? I might be able to look at this and say, okay, if it mirrors it, it's early. If it's after it, it's late. And if it has an abrupt drop, it's variable. But how do I know what's going on with my baby when that happens? And that is where VealChop comes in. So VealChop is just a little tool to remember what's going on. And so you guys aren't ever going to be asked to read tracings like for your tests and HESI and stuff like that, but you might be asked, your baby has this type of deceleration, the nurse knows that the cause of this is what? Okay. Or the baby is experiencing core compression, the nurse anticipates this type of deceleration. And this is why VealChop is a helpful tool. So what we're going to do VealChop is we're going to write the word veal down in a line. And then next to it, we're going to write the word chop. It helps if I can spell. Down in a line. Okay. And then now you can go back and forth between these and it'll remind you what each of these are. So V is the variable and it's caused by core compression. E is early deceleration caused by head compression. A is an acceleration. Accelerations are okay, or it can mean they're O2, where you've got oxygenation. That's good. And then L is the late and it's caused by a placental insufficiency. Okay. So that is fetal monitoring in a nutshell. Okay, so let's move on now to reassuring and non-reassuring for fetal heart and for uterine activity. So fetal heart rate, what's reassuring? Stable fetal heart rate between 110, 160. Moderate variability, accelerations, 15 by 15, right? Uterine contraction frequency. So this with uterine contractions, do we have that on the next slide? Let's jump ahead and do uterine contractions, and then we'll go back to what's reassuring. So uterine contractions. What am I thinking about for uterine contractions? This is going to help the cervix dilate or open. It's going to help the cervix thin or efface. And we're looking at the timing and we're looking at this. Okay, so here's a contraction and look at this baby has moderate variability and here's an acceleration. So that's great. So this says contractions can be measured from peak to peak. The way I learned to measure them is from beginning to beginning. Either way, that's going to get you the same answer. That is how often they're happening, from either the peak of one to the peak of the next, or from the beginning of one to the beginning of the next. And on the tracing, each of these red lines is 1 minute. So if I count from the beginning to the beginning, and I go 1, 2, 2.5, almost 3 minutes here. If I count here, this one starts right here and say 1, 2, 3. So they're every 2 to 3 minutes. And same is true with the example, they counted the peaks and they still get the same answer. Okay. Now that's the frequency. How often is she having contractions? And so from one contraction to the next. Now we will also count the duration. How long is it lasting? And so each of these lines, the gray lines, are each 10 seconds. So if her contraction starts here, I can say 10, 20, 30, 40, 50, 60, 70 is the duration of her contraction. 70 seconds. Okay. Now, if her contractions are lasting longer than 90 seconds, that's a long time. And that's when we have decreased, and I think I have it on here, the duration greater than 90 seconds may reduce fetal oxygen supply. Okay, so that's our duration. This is our frequency. And then we also look at the interval from when one ends and the next one begins. And I would like to have a good solid minute between when one ends and the other one begins so that baby can get a break. Remember, when the uterus is contracted, I have less blood flow. Okay. So timing from beginning of one to beginning of the next for frequency, report frequency greater than 2 minutes. If they're happening more than every 2 minutes, that's too fast. That's tachysystole. Okay. Duration is the timing from the beginning to the end, and we're going to report if it's greater than 90 seconds because that's what can feed fetal hypoxia. We're going to determine if it's mild, moderate, or firm. And we can practice palpating the belly and then feeling our face. And if you touch your nose and squish on your nose, that's about what her belly will feel like with a mild contraction. Chin is about what her belly will feel like with a moderate, and forehead is what her belly should feel like with firm. Okay, so and then when you palpate a contraction, those are the things you're thinking about. And then here's the interval, timing from the end of one to the beginning of the next. And we're going to report if this is less than 60 seconds. Okay, so back on this slide here. This one, if I have an intrauterine pressure catheter in, I can measure I told you it measures it in millimeters of mercury, and that's the MVUs. And so this, I don't actually know if this shows up anywhere for you, but I wanted you guys to understand it, that then I'm quantifying the actual pressure of contractions. And then I measure it over a period of 10 minutes. And I take the actual pressure from the baseline to the peak, and I add them all up. And that's what makes my Montevideo units. But tachysystole is more than 5 contractions in 10 minutes. So that's going to be ones that are lasting, that are closer than 2 minutes apart. A series of single contractions lasting greater than 2 minutes, too long. Or contractions of normal duration occurring within 1 minute of each other, that is too short of an interval, right? So we would report that. So if we go back to what's non-reassuring, uterine contractions, frequency greater than every 2 minutes, duration less than 90 seconds, or relaxation interval needs to be at least 60 seconds. Okay, this is reassuring if they're more than 2 minutes apart, lasting less than 90 seconds, and we have more than a 60-second break. Non-reassuring, fetal tachycardia, so sustained baseline greater than 160. Bradycardia, sustained baseline less than 110. Decrease in or absent variability, which is that fluctuation in the rate. So if we have minimal or absent, that can be non-reassuring. Late decelerations and variable decelerations, which we just looked at. Those are non-reassuring findings. So what do I do about non-reassuring findings on my heart tracing? So if we are going to just think about it quick, the very first thing I should do, guys, is turn the patient. Change her position. Because think about if we're thinking that our non-reassuring decelerations are late decelerations and variable decelerations, a position change might fix either of these. Because on your late deceleration, we have a placental perfusion issue, and changing her position could help perfuse the placenta. Also true if it's cord compression with our variable decelerations, changing her position could shift the pressure on the cord. So the best thing to do is going to be to change her position first. All right. We also need to consider giving her IV fluid. We can give her oxygen via a face mask, or non-rebreather. And actually in practice, guys, you're probably not going to see this anymore because we are getting away from using oxygen in practice, but it's still on in your book and on your stuff. And we need to notify the provider. And it says any fetal heart rate outside the normal limit and any slowing of the heart rate that persists after the contraction ends, which is what kind of deceleration? Late. We're going to report that to the healthcare provider. Okay. Other things, if we use this other mnemonic, these are things we're thinking about a little closer. So we are still thinking about the position change, and we are still thinking about oxygen, and we are still thinking about IV fluid. But here's the thing. Remember, if she's contracting a lot, that affects the way we perfuse our baby. So if we're giving her Pitocin to cause contractions, we probably need to turn it off. Also, I can give her a medicine, and it's called terbutaline. And terbutaline will slow contractions down. It's a tocolytic. And terbutaline actually is an asthma medication that works on the smooth muscles in the lungs, but it also works on the smooth muscles of the uterus, and it makes those contractions slow down, and it gives baby a break, and it gives opportunity for placental perfusion. The thing with terbutaline, guys, is that it causes tachycardia. So I want to do vital signs on the front end. I want to know what her heart rate is to start. And I've said, if we're at the bedside and we're having decelerations and the doctor says, let's give her terbutaline, I'll say her heart rate's 120. Do you want to give it? Because it's going to make her heart rate go up more. Okay. And then our blood pressure. So guys, next week, I think it's next week, we learn about pain management. In labor, and we're going to learn about epidurals, and epidurals can cause the blood pressure to go down. This is a prime example of what could cause a low blood pressure that could cause us to have late decelerations. And so I might need to treat the blood pressure. And so I'm considering that as well. Which fetal heart rate pattern would be a priority? A decrease in the fetal heart rate that occurs after the peak of a contraction, a fetal heart rate deceleration that occurs at the acme of a contraction, an increase in the fetal heart rate to 180 that quickly returns to the baseline, or a fetal heart rate deceleration that abruptly drops 20 beats, lasts for 20 seconds, returns to the baseline with moderate variability. So this first one, it says occurs after the peak of the contraction. That's late. Fetal heart rate that occurs at the acme of a contraction. Acme is the peak. So if the deceleration is happening at the peak of a contraction, it's mirroring it, that's an early. An increase in the fetal heart rate to 180 that quickly returns to baseline, that's an acceleration. And fetal heart rate deceleration that abruptly drops 20 beats, lasts for 15 seconds, and returns to baseline with moderate variability. The key word here is abrupt. Abruptly drops, we know it's more than 15 beats. We know it lasts longer than 15 seconds. That's a variable. And our answer for which is the priority is A, the late deceleration. Okay, so we talked about this already with contractions. So onset and stages of labor. Labor is going to be defined by the contractions that are changing the cervix and causing it to dilate in a face. And so our onset usually happens because the progesterone goes down. Remember, guys, progesterone is what is maintaining the pregnancy. Okay, and so the progesterone goes down, the body's releasing its own prostaglandins that soften the cervix up. Oxytocin is being released from the body's own oxytocin to makes the uterus contract. Okay, stages of labor. So our first stage is the onset of labor to full dilation, and full dilation is 10 centimeters. Okay, and we break this down further into phases. And so when we watch the little video with the balloon, she says this is like what's happening in early labor. She's talking about the early phase or the latent phase of labor where we're getting a little bit maybe dilation, but more effacement. We're thinning out. Remember what we talked about with the thinning. Okay, active phase of labor. Now we are dilated more. Your book, I think, might still say active phase starts at 4 centimeters. In a different place, it says 6 centimeters, and we're really using 6 centimeters as when our active phase starts. Okay, there's a lot of people that walk around 4 centimeters dilated and they're not in active labor. So 6 centimeters to 10 centimeters. This is our active phase. There's a lot more dilation happening now. Okay, those contractions are really effective and we're making good progress. The other phase here is called transition. And transition phase is usually around 8 centimeters dilated. And in the transition phase, if she's unmedicated, she starts really wanting to bear down. She starts feeling that urge to push. Okay, and so she will maybe say, I feel like I need to have a bowel movement. She might be grunting and kind of sitting sideways and going, and I feel like I need to poop. Okay, this is transition. Her body's making the transition from first stage to second stage. And during this time, guys, this is when it's the most important for us to help her stay in control. Because if she pushes on that cervix that's not gone yet, it can swell and it can tear. Both are bad. Okay, and so we want to help her with her breathing. There's a lot that we do with breathing and staying in control in labor, and it's especially important right now. We're going to have her blow out in short puffs. And what happens with that is it brings the diaphragm off of the fundus and relieves a little bit of pressure. It also helps her focus so she's not bearing down. Okay. And so and usually this phase is short, thankfully, because they're miserable. The second stage of labor happens when she's fully dilated. She's 10 centimeters, there's no cervix left, and this is the birth of the baby. Okay, so we have a fully dilated cervix, and now she's going to push. So now that's our secondary power, right? And so she's going to push and she's going to deliver this baby. Okay. Third stage happens when the baby delivers, and now we're waiting for the placenta. And this can take as long as 30 minutes. So you should have 2 nurses here. One is doing baby, and one is still the primary nurse for the mom. And then the fourth stage of labor is the first 2 hours after birth. So we're going to look at this a little closer. The second stage of labor begins with what and ends with what? Second stage begins with complete dilation and effacement of the cervix and ends with delivery of the baby. That's the correct answer. So false labor versus true labor. Okay, with false labor or our Braxton Hicks contractions, they're usually irregular. Usually if she walks around, the contractions subside. Okay, don't usually have bloody show. Her cervix shouldn't be making change. In true labor, those contractions are getting more regular, they're becoming stronger and more effective when she walks. If I send my patient walking, she comes in, she's like, I think I'm in labor, I'm having contractions. I put her on the monitor, I check her tracing, her baby looks good. I send her walking. And then what does her contractions do? If she comes back and she's like, oh my gosh, they're getting stronger, they're getting closer together, they're really hurting, maybe she's changing her cervix. Okay. Usually with true labor, the contractions start in her back and radiate to the lower part of her abdomen. And in false labor, they often feel it higher, like above their belly button. True labor might have bloody show. And now we are getting cervical change. So comfort and coping. We're going to spend a lot of time talking about pharmacological and non-pharmacological pain management next week. But some of the things we're considering for this, okay? We need to help moms with how they're perceiving their pain, how they're expressing themselves. We need to help them with control, focused breathing, distractions helpful, lots of position changes, especially in early labor, keep her moving around. Helping her deal with anxiety. Okay, helping that her keep that breathing controlled. Oftentimes, if moms get panicky or if the pain's getting severe, they start to hyperventilate. And then they're like, I can't feel my hands and I'm really dizzy and lightheaded. And so we can actually, if you guys remember when people are hyperventilating, and I remember as a little kid, you see even on the cartoons, like with the bag, right? Truly, you have probably already learned that the idea behind that is to rebreathe the CO2. And so we can help moms do that by having their breathe in their cupped hands a little bit if they do start feeling tingly. But we want to try to minimize hyperventilating. We're doing a lot of teaching, we're educating and helping them understand what's happening with their body and that this is normal, and a lot of support. Oftentimes, especially moms that are anticipating an unmedicated labor will have a doula. And a doula is somebody they hire. Doulas actually make really good money to come and give them emotional and physical support through their labor. And the doula might stay through the entire labor unless they work for a company where they switch out. And so a good doula is worth their weight in gold on labor and delivery. Okay, supporting and teaching the partner. So we need to support the dad or whoever the partner is, right? And we need to also provide them with the teaching, help them support their partner, help them bring a lot of those skills that a doula brings to the bedside. Okay, my patient last night, they came in 7 centimeters that we were doing intermittent monitoring on. She had her mom there, she had her husband there. And so I can give a lot of that support at the bedside, but timing doesn't always allow for that. So teaching them how to support her is very important. And then taking care of her support system, getting them drinks, getting them coffee, whatever. Later, when she's resting, helping them rest, things like that. All of these things are really important. But teaching them how to support her, having them help her, because truly, if I have a patient who's having a hard time with breathing through her contractions, she's going to listen to her partner before she's going to listen to me. So I teach the partner how to help her breathe, and then I tell her to listen to him. Okay. Non-pharmacologic pain management, we'll spend a lot more time on this. There's a lot of things you can do. Counter pressure, especially for that OP baby and that back labor, counter pressure is so helpful. Just right here on the lower part of the back with the ball of your hand. Okay. Therapeutic touch, light massage, hot, cold, water, all sorts of stuff. And then positions that we can be in for labor. There's so many positions, and actually for those of you that want to do OB, there's even Spinning Babies looks at the physiology of how the baby is fitting through the pelvis and what can we do to get that baby in a good OA position, and how do we make space in the pelvis. So there's a lot of really interesting information about that, and all of these different positions to labor in are also good positions to deliver in if your provider is open to trying it. A client is admitted to the birthing suite in early active labor. The priority nursing intervention on the admission of this client would be what? Auscultate the heart tones, take an obstetric history, ask the client when they last ate, or ascertain whether the membranes are ruptured. The very first thing I want to know is, how's my baby? So we're going to auscultate the fetal heart. Okay. These things are important. All these other things are important, but the priority is the fetal heart rate. So 10 centimeters to delivery, we're going to have a baby. Okay, we're teaching her how to push, and pushing can take 2 to 4 hours, especially with a first baby. It can take a really long time. And during this time, we are changing her position. We are helping her relax. We are assessing the baby, and we actually chart on these babies every 5 minutes with pushing. We can do warm compresses, cold compresses. We're keeping the environment calm. We're also preparing supplies for the healthcare provider for delivery. We're helping the dad or whoever the support person is. Okay. And this environment is a lot of this is how they want it to be. Okay. If they want music, if they want the TV on, I had one that watched TV the whole time she was pushing. Others that want it dark, quiet. There's a lot of different things that go into this. So now our baby comes out, and our baby's going to go skin to skin. And skin to skin is the best place for thermal regulation to help the baby body temperature. It's a good place for bonding. It's a good place we are going to do what they call the golden hour. We're going to keep that baby skin to skin for at least the first hour. So that's why it helps to have 2 nurses. And I usually have a blanket here for this because our baby comes out, and now we're going to use a towel or a blanket, and we're going to dry our baby off and gently stimulate our baby. Okay. And so we're drying and stimulating. This is the end of stage 1 and the start of stage 2. Mom's going to be working on delivering her placenta, and we're taking care of the baby. So we're drying the baby, we're stimulating the baby, we're assigning APGAR scores. And the APGAR score, we assign this at 1 minute of life on every baby and at 5 minutes of life. And both of these charts mean the same thing, but they show it in a different way. Okay, so the APGAR score is your appearance, your pulse, grimace, activity, and respirations. And they either are doing it really well and they get 2 points, they're not doing it at all and they get 0 points, or they're doing it a little bit and they get a point for trying. Okay, and so if they're completely blue, no points. And truly, in Colorado, where we have a higher altitude, oftentimes at 1 minute of life, our baby's not pink yet. Okay, and they'll lose points here. Pulse, greater than 100, less than 100, or no pulse. Our grimace has to do with how our baby responds when I stimulate him. And so there's a lot of examples on here. Mostly what I'm looking at when it says pulling away when stimulated, that's kind of what I'm thinking about. What I want to do is I want this baby to cry. Remember, we talked about gas exchange, and I want that baby to cry, clear that fluid out, and get good gas exchange going to the lungs. And a good way to do that is to mess with their feet. And it makes them cry and they try to pull their foot away from you. And that gives me my reflex irritability, which is grimace. Okay. Activity, are they moving? I have had some babies that come out limp and floppy like this one, like this bear, like truly. This is what the baby looked like. Okay. And then respiratory effort. So even though both of these scoring systems say strong cry and vigorous cry for respiratory effort, not every baby cries. So if they're breathing well, and I am listening to their lungs and they're moving air and they have a good respiratory rate, they can still earn 2 points, even if they're not actively crying. But crying is better. Crying is going to clear those lungs out. It's going to let me know that they are getting good gas exchange. Okay, so assessing at 1 minute of life and at 5 minutes of life, and then to continue assessing every 5 minutes for up to 20 minutes if our score is less than 7. And that's why this other tool is kind of helpful, because it tells you if we are 7 to 10, we're doing good. If we're 4 to 6, not so much. If my baby's in the 4 to 6 range, I am going to continue to gently stimulate that baby and see if I can still get that cry. Okay, see if I can get these points up, because it depends on where we're losing points. But if maybe they're kind of floppy, we don't have great muscle tone, they're not really, irregular breathing, things like that. If I continue to stimulate this baby and kind of rub on them gently, we can oftentimes get that response and get the APGAR to come up. If I have a severely depressed baby, 0 to 3, this baby is going to the warmer and I'm calling friends for help and we're doing a lot of things to resuscitate. That's a severely depressed baby. Okay. Cord blood gases. I love the picture for this because I have asked you guys what carries the oxygen. And you guys know the vein carries the oxygen. This big fat vessel is the vein. Okay, this tiny one here is one of the arteries. Okay, it's not easy to see both of the arteries in this picture, but this is one of the arteries. The artery, though, is going to give me a really good picture of how my baby was doing at birth. So if I have a low APGAR score, then we might draw blood from the artery and send it to the lab to see if the baby's acidotic. Okay, and if I look at the blood from the vein, it's going to tell me what was coming to the baby from mom. So the baby comes out, somebody's taking care of the baby, drawing, stimulating, skin to skin, assigning APGARs, and the primary nurse is still helping the delivery provider with the third stage of labor. And the third stage of labor is the delivery of the placenta. Okay, so if we look at a placenta, this is the side that was on mom's uterus, and this is the side that was facing baby. The nurse can get cord blood. So we can get the cord blood here if we needed it. We can also take a whole blood cord blood sample to determine the baby's blood type. Now I'm going to know if my mom is Rh negative and my baby's Rh positive. After the placenta comes out, we're going to give oxytocin to manage the uterus and get it to squeeze. So in labor, squeezing the uterus decreased blood flow to the placenta. Now I want the uterus to squeeze and contract and decrease blood flow to where the placenta used to be so that she doesn't bleed too much. And once the placenta is out, we're massaging the fundus. So if you think back when I showed you guys the anatomy picture the first week, and I said, when I talk about these things, I want you to be able to see it in your head. The fundus is the top of the uterus. And we're going to massage it to help that uterus contract and tamponade on those vessels. Fourth stage of labor, for moms now, the placenta is out. We are assessing her vital signs. We're managing her pain. If she's had an epidural, then we're waiting for her, that is turned off, and we're waiting for her to recover from that. We're going to put an ice pack on her bottom. Her vagina and perineum have been through a lot, and that's going to help with bruising and bleeding and swelling to the site. We're going to manage her bladder, especially if she has an epidural. She's not feeling that yet, so we're making sure her bladder's not getting full and distended. And we're assessing the fundus, making sure that it's firm, right? We want it to be contracted. If our fundus is boggy, I'm worried she's going to bleed. I'm worried about hemorrhage. So the very first thing I'm going to do is massage it and try to encourage that muscle to contract. And so here, if we were in class, I would ask you what kind of things I'd be watching for. If I'm worried about hemorrhage, if her fundus isn't firm, what kind of symptoms might I see if she's bleeding? Okay, so think about that. Think about what we know about hemorrhage or hypovolemia. Her heart rate's going to go up. Her blood pressure is going to go down, right? We might see, as we massage, we might see big clots coming out. We might see a continuous little trickle of blood. She might keep saturating pads. All right, she shouldn't be saturating a pad on postpartum, we say a pad an hour. We, right after delivery, are a little more accepting on what's coming out right at the very beginning. So it's going to be more like, depending on the size of your pad, a little bit more than that. So like, I don't know. We're facilitating breastfeeding, helping with latch, helping with attachment and bonding, keeping that baby skin to skin. And we're going to start taking care of our baby now. So we're watching mom, we're assessing mom. So now the baby just came out. So we have to go back to the baby part. And so the baby came out, we're vigorously, gently drying and stimulating the baby. We're doing our APGAR scores we just talked about. We're going to do gentle stimulation if our APGAR score is less than 7. Skin to skin for thermal regulation and bonding, promoting thermal stability. We call it the golden hour to help promote bonding. We keep this baby with mom for at least an hour. We get the baby breastfeeding. We can do a visual assessment, looking for like major anomalies and stuff like that, but we're not taking the baby off of mom's abdomen unless it's medically indicated. Okay. Breastfeeding, I said. We're seeing if the baby voids. We'll delay the cord clamping. Okay, because that when the baby's out and the baby's on the skin, we wait at least a minute so that we get good perfusion for the rest of the blood from the placenta to baby before we clamp the cord. And then after that first golden hour, we're going to do a more thorough assessment of our baby. And we're going to do what we call eyes and thighs. And there's a skills information in your book, page 159 and 160, where we're giving the erythromycin eye ointment. We're giving vitamin K injection. And the vitamin K injection is helping with blood clotting. It's helping the baby's body develop its own clotting factors. And the erythromycin eye ointment protects the eyes from conjunctivitis that can be caused by chlamydia and gonorrhea. Okay, and then getting the cord blood like we talked about. The nurse is examining a woman 1 hour after birth. The woman's fundus is boggy midline and 1 centimeter below the umbilicus. Her lochia flow is profuse. I don't ever want to hear that word describing lochia flow. That sounds horrible. And 2 plum-sized clots. The nurse's initial action will be to do what? Place her on a bedpan. Oh, shoot. Hold on. That is definitely not what I intended. We're almost to the end. Let me find our slide. Place her on a bedpan to empty her bladder. So worth saying just for a second, that's not the answer here. But if the bladder's full, it's putting pressure on the uterus. Okay. And if it puts pressure on the uterus doesn't realize it needs to contract. And so managing the bladder is important to help reduce the risk of hemorrhage, to help reduce bleeding. So emptying her bladder is not a bad idea, but this is not the initial thing to do. Massage her fundus. Call the physician. Administer Methergin 0.2 milligrams IM, which has been ordered PRN. Guys, all of this stuff needs to happen. It does. Okay, I need to massage the fundus and make the uterus contract. I need to tell the doctor she's bleeding. I need to give medicine to try to help her uterus contract better. And I need to manage her bladder. And I'm not getting her out of bed to go pee if she's got profuse lochia. So a bedpan's a good idea. Actually, I probably would place a Foley catheter. But the most important initial action here is to massage the fundus. The reason for this is if she's bleeding profusely, like the word said, and I walk away to go call the doctor, how much blood am I losing right now? Okay. This doctor that I work with says, he quotes a source that he read that says that 6 minutes is the amount of time that a woman could lose her entire blood volume through her uterus if it wasn't managed. Okay, so if I go to call the doctor, how much blood am I losing? And so better still is going to be to massage the fundus and call, and while you're massaging, call and have somebody help you do these other things. Pull your call light, pull your emergency cord, get somebody else to call the doctor for you. Somebody's got to be on that fundus massaging it and getting that, you're trying to get that muscle to contract down, because that's what's going to help the bleeding. Okay, so B is the correct answer for this. This week we are reading chapter 6. You're going to turn in you're going to do, and it flows to the grade book, the case study for gestational diabetes. And we're taking exam 1. So the exam 1 prep announcement has study material, it has study sessions, and it has recordings of the study sessions. Please make sure you download your exam before exam day. And then next week, we're reading chapter 7 and 8, and we are doing quiz number 3. So remember on your quiz that counts towards your KGA, and to make sure that you have done all of the class stuff for the week before you take your quiz. All right. And that is the end of week 4. Have a great day.